Hello, for those of you who don't know me, I'm Sarah Germana. I'm one of our nursery pediatricians, and today I just wanted to address a few topics related to newborn care. This is a brief outline of what I'm planning to touch on today. First of all, I just wanted to briefly discuss the handoff tool for the newborn nursery that has been implemented over the last few months, and wanted to discuss briefly why we think it's important. The goals of it are really to improve communication between the labor nurse and the delivery nurse. For example, it's not adequate handoff to roll the baby into the nursery and say, "This is baby X and I don't know anything about them, but someone told me to drop them off." The other issue is that we really wanted to make sure there were clear triggers for notifying the pediatricians about babies born overnight, which is particularly important because during those overnight hours, the babies may not be admitted by a pediatrician until the following morning. Some examples of these issues that we do feel are more time sensitive include indications for glucose monitoring, mom's hepatitis B and HIV status if she's positive or unknown, particularly since these are diseases that, if not acted upon in a timely manner, could make the difference between these being transmitted to the newborn or not. Also, if there's a blood type incompatibility that would put the baby at need for early screening for hyperbilirubinemia, and then also any sepsis risk factors or issues related to GBS that could require a workup in the infant. This, I know, is not very readable on your handout, but I just wanted to include it because this is the handoff tool, and just make sure that everyone knew what I was referring to, and also just to highlight a few of the areas where there are triggers for notifying the pediatrician. I wanted to speak very briefly about Group B strep guidelines just because the guidelines were updated in November of 2010. Some of the changes that came about in the updated guidelines included new definitions of what was considered adequate antibiotic prophylaxis for Group B strep, as well as the algorithm for managing newborns in order to prevent early onset Group B strep infection. The actual indications for interpartum prophylaxis haven't changed, namely moms who are Group B strep positive, or if they're unknown but have a risk factor of preterm delivery, prolonged rupture of membranes, or maternal fever. These are all moms who require interpartum prophylaxis unless they have a scheduled C-section where there's no labor and no rupture of membranes. If she has either labor or rupture, then the above applies to her. I'm not going to go through the updated GBS algorithm for infants in detail, except to highlight that one of the main changes in the algorithm is that basically doing less blood work on babies than we used to and relying much more on our clinical observation of the infant. The reason that this is important is because we become all the more reliant on some of the clinical signs of sepsis, and many of these are related to vital signs as well as feeding. Hence, I wanted to touch very quickly on vital signs and what we're considering to be abnormal ranges, since this may be the first sign that an infant is septic. These are the vital sign ranges that we're considering normal, namely temperature 36.5 to 37.5, heart rate 100 to 180, and respiratory rate 30 to 60. If an infant has an abnormal vital sign, for example, they're bundled really well and they have a slightly high temperature, or they're screaming and crying and they have a slightly high heart rate or respiratory rate, then it would be important to recheck it about 30 minutes later to make sure it's normalized. And if it hasn't normalized, then that would certainly be an indication for notifying the pediatrician. The other quick thing I wanted to mention about this was just that some of the indications for checking more frequent vital signs and not just doing the every 8-hour vital signs are infants who are born preterm, infants who are on phototherapy because they're at higher risk for dehydration or temperature instability, as well as infants who do have sepsis risk factors. Related to phototherapy and hyperbilirubinemia, there's often confusion about what's considered single phototherapy versus double phototherapy because it refers to the intensity of the light and not to the number of devices. So some things that count as single phototherapy are either a Billy blanket or the large overhead neo blue on the single setting, whereas the Billy bed, the overhead mini blue, or the overhead large neo blue on the double setting are all double phototherapy. Having said that, the efficacy of phototherapy is also dependent on the surface area that's covered, and so that's why often we see that the overhead neo blues are more effective than the Billy bed because they actually cover more surface area. The other thing is that is the reason why it is important to make the diaper as small as possible, take the hat and socks off, and anything else that would be blocking the light contacting the skin. The other important thing is that obviously phototherapy only works, the treatment only works if you actually use it. And so the importance of that is that it is important to start the phototherapy as soon as possible after it's ordered, and it's important to try to remind and encourage the parents to keep the baby on it as much as possible, and just to, when they do need to take the baby off for feeding, to minimize that period of time that they're off. Our guidelines in the nursery say that we are only supposed to use double phototherapy with a single device unless it's in extreme circumstances with the attending being aware and so on and so forth. So that would typically be a Billy bed or the overhead neo blue. I'm not going to delve too much into breastfeeding because I know the lactation consultants are giving a skills day session as well, but I wanted to mention it because even though there is a lactation consult team, we really are all involved and all important in breastfeeding, and it is important for us to help educate and advocate for breastfeeding. And some of the ways that we can all do this are not only providing assistance with positioning and latch, which is particularly important in the early hours when you're really making a difference in establishing mom's milk supply, but also thinking to ask about not just what is mom doing, but what is her intention, what is her goal. Is this a mom who is bottle feeding because that is her plan to bottle feed, or is she bottle feeding because she thinks her milk isn't in yet and that she feels like she needs to bridge the gap until her milk comes in? We can all also help to provide education about the normal lactogenesis process, and to while being supportive of mom's choice, also making sure we're educating and discouraging formula supplementation unless we feel it's medically indicated. And then certainly initiating pumping and lactation consults if they're indicated, which I've just listed here some of the indications for lactation consultation, which most of you are very familiar with. And then I want to move on to discharge teaching, which I wanted to mention because I think it's important for us to give consistent information to make sure we are increasing parents' trust in us, make sure we are improving parent satisfaction, as well as decreasing confusion and decreasing risk by providing mixed information. So related to this, one of the reasons that we tell parents to at least talk to their pediatrician or have their baby seen right away is related to fevers. And the reason why that does need to be brought to the pediatrician's attention is because infants less than 3 months old who have a temperature greater than or equal to 100.4 automatically get a workup, antibiotics, and possibly hospitalization because of the risk of this being a sign of serious bacterial infection. Studies have shown that rectal temperatures are the most accurate, and axillary temperatures can not only be falsely low because they are peripheral and not core, but can also actually be falsely high because of the higher amount of brown fat that infants have. Both of those carry risk, not only because of missing a possible serious bacterial infection, but also, if you overcall it, you could lead to unnecessary testing and hospitalization. It's important for us all to not only teach and encourage, but also to model safe sleeping practices in the hospital, namely sleeping on the back, which has been shown to be safer than sleeping on the side, even in babies who are spitting up. Avoiding fluffy blankets, pillows, stuffed animals, everything else in the crib or bassinet except the swaddled baby. And then avoiding co-sleeping. It does decrease the risk to have the baby sleeping in the same room as the parents, but it certainly increases the risk if they are co-sleeping, especially if this is in association with smoking. Related to umbilical cord care, I know there's a lot of questions and controversy about this topic, particularly because a lot of nurseries have moved to doing dry cord care. And so I wanted to add my 2 cents on the topic. There have been shown to be lower rates of bacterial colonization with alcohol, although this hasn't necessarily correlated with lower bacterial infection rates. There is a lot more odor and exudate in infants who have dry cord care, which leads them to seek more medical attention. But there's also somewhat delayed cord separation with use of excessive alcohol as compared to dry cord care, although the difference is a couple of days, which in the grand scheme of things isn't a huge difference, I don't think. So I can tell you that most of the pediatricians in our practice, even the ones who work in nurseries that have gone to dry cord care, most of them recommend alcohol 1 to 2 times a day. But we all agree that doing it significantly more than that is probably not only not necessary, but is probably actually a negative. And 2 things that I just wanted to mention very briefly because they are things that you may be hearing more about in the next few months. The first is that we are likely going to be having some changes to our glucose monitoring protocol. It's still going to be the same infants who have indications for glucose monitoring, but some changes may come about based on some new guidelines that came out from the AAP in 2011. The main changes being that they are suggesting the acceptance of lower cutoff values for glucose, recommending more prolonged monitoring and not stopping after 2 normals, and then also making a differentiation between symptomatic and asymptomatic newborns. And so we are working together with ICN, the SCN, and Durham Regional and the other hospitals in our system in order to come up with a unified, updated glucose protocol. The other thing that you may have heard about in the news recently is the use of pulse oximetry screening in order to help screen for congenital heart disease. And this, probably in the relatively near future, is going to become a part of the recommended newborn screening, much in the same way that the newborn screening blood test and hearing screen is. And the screening would be done with a pre- and post-ductal SAT before the baby is discharged from the hospital. Infants who have an abnormal would proceed to echocardiogram. And this, like the glucose management protocol, this is in the very early stages of planning, but more to come in the future.